Okay, this is Dr. L, and now we're going to talk about how do you know if a person has TB. So diagnosing TB relies on a number of things. One is a physical exam of the patient. There is a skin test. I'll talk about that in a minute. There is a blood test. Typically chest x-rays are done to look for those granulomas, and a sputum or spit sample, where they use a staining protocol called the acid-fast staining protocol. So typical gram staining does not work for Mycobacterium tuberculosis because of the mycolic acid in its cell wall. So instead there is a different protocol called acid-fast staining. And you can see the tubercle bacilli in here. They're like these red, long red, rod-shaped bacteria. And this red reaction is not a gram-negative pink, as you would see in a gram test. It is the result or the color that you see in a TB bacterium when you stain like a sputum sample, and the bacteria are present if the person has active TB. And when you do this acid-fast staining protocol, you'll see these pinkish purple results. These the blue stuff is background human cells. So there's something called the TB skin test, or the Man-2 tuberculin skin test, or the TST. It requires two tests, 2 visits with a healthcare provider. And what will happen is on the first visit, the healthcare provider will inject a solution of what's called tuberculin, which is it's not a vaccine and it's not a drug. It is the antigen from the Mycobacterium tuberculosis. So it is the part of the exterior of the bacterium that triggers an immune response. And so you'll get that antigen injected, and you'll come back, it's 24 to 48 hours depending, and the healthcare provider will look at the site of injection. And if you see a big swollen response with red all around it, and it matches up with the criteria that'll be actually measured, that will show that you had a positive response. And what that tells the healthcare provider is your body has seen, your immune system has seen that bacterium before, and so it is quickly mounting an immune response to the antigen, the calling card of the bacterium. If you've never experienced tuberculosis bacteria before, you really won't see any sort of a response. And so this can be complicated. This does not necessarily mean you have active or latent TB. You may have had TB before and been cured. You also may have grown up in a country like Ireland where you received the BCG vaccine, and then you will always be positive with the skin reaction even though you yourself do not have tuberculosis. So it's not 100%, but it is a useful in public health test. There's a blood test for TB, and it relies on detecting the antibodies to tuberculosis. It's called an interferon gamma release assay, or IGRA. It tells us a positive result tells you that you're likely to have been infected with Mycobacterium tuberculosis or other causative agents of TB, but you will need additional tests. And a negative response says that the person's blood did not react, therefore it's very unlikely that there is a latent or active infection. So there are other tests. So as I said before, for example, x-rays are important. Now I'm going to move on to treatment. So this is a bacterial disease, and so the treatment is to take antibiotics. Antibiotics are the chemicals that we take internally to treat bacterial infections. So for example, penicillin. It is very difficult to find an antibiotic that will kill Mycobacterium tuberculosis. So while other antibiotics like penicillin was actually discovered in the 20s, but it was first brought into medical practice in the 40s, the very first drug to treat that was effective against tuberculosis was streptomycin. It's really no longer used clinically for TB today, I believe, but it was formally, announced October 19th of 1943. It was discovered by student Albert Schatz and Selman Abraham Boxman at Rutgers University in New Brunswick, New Jersey. I actually had the blessing of doing a postdoctoral studies at Rutgers and literally worked in the very same lab where this drug was discovered. And I can tell you that nobody had cleaned up since. Quite a messy, dirty old lab, but still a great place to be. Rutgers is kind of a mecca for microbiology, and I was really fortunate to get to work there. So the Nobel Prize was actually given out for this discovery. It's a really big deal. So today's treatment, if you have latent TB, then what will happen is you will go on what is called preventive therapy. It may cure and eliminate the bacterium, but it may not, as I said earlier. And so those drugs, the most common one used is a drug called isoniazid, and it's a form of the drug called INH. And typically it's a single daily pill for 6 to 9 months, a very long-term treatment regime. Very complex. If you have active TB, it's much more complex. So there, for a minimum of 6, often as long as a year, you will need to take a combination of the isoniazid antibiotic plus 3 other antibiotics, most commonly rifampin, pyrazinamide, and ethambutol. These are not drugs that are used a lot for other infectious diseases. These are really TB specific, okay? The person will have to be isolated until they're determined to be non-infectious. So you'll be in the hospital quarantined, and then you will be home quarantined. You will not legally be allowed to leave your house. This is very, very serious. You will receive what is called directly observed therapy. So you'll have a public health nurse come and observe you taking your medication and also just help you, right? Because it's very difficult to go through this. This treatment regime is very complex, and there are terrible side effects and terrible toxicity. So it's very common to lose massive amounts of weight and experience a lot of pain and disruption just from taking these drugs. It's very, very difficult to go through. There's a stigma to having TB, and you can have complications with other diseases. You can have other drug-drug interactions. So it's really difficult and really expensive. Unfortunately, drug resistance is a growing concern in Mycobacterium tuberculosis. So there are still many strains that infect people that can be cured and treated with regular antibiotics, but there is something called multi-drug resistant TB, where you see resistance to isoniazid and rifampicin. There's also something called extreme drug resistance TB, where we see resistance to isoniazid, rifampicin, the fluoroquinolones, amoxicillin, kanamycin, and I forget what CM is, but it's another drug sometimes brought out to treat TB. And then what we also are starting to see from time to time is what's called DRTB, which is unfortunately TB that is caused by a pathogen that is resistant to every single available antibiotic, and those patients die. There is no saving them. So we are seeing more and more resistance, and we're seeing more extreme forms of resistance. So this makes this a pathogen a really good one to learn about for lots of reasons, one of which is understanding the concerns that we have related to antibiotic stewardship and why it matters. So we do try to prevent TB by controlling infection, by documenting it, by monitoring cases, using testing, using treating, using DOTS to try to control and curb it. Some countries, Ireland for example, uses a vaccine called the Bacillus calmette-guerin vaccine, BCG, to reduce pediatric TB. It is not effective against adult pulmonary TB, so and it does complicate things like the skin testing. So we do not use it in the United States because we don't have a high burden of endemic TB. Other ways or things to think about in terms of prevention is that this is a social justice issue. So you will see a lot of TB in where you have overcrowding and lack of access to care. So a lot of prisons, for example, TB is a terrible problem. All of this could be dealt with, with more social equity and more access to care. So it's something to think about too. So that vaccine, I'll just mention it again, it's not effective against pulmonary TB, and it does complicate skin testing. But it does reduce the incidence of pediatric TB, and that is helpful in countries that have higher levels of endemic TB. Ireland historically has always done use this particular vaccine in other countries in the world. So, so it is still used. I believe it's still used in the U.S. military, and it may be used in certain healthcare workers. So, with that, I'm gonna conclude. Just gonna ask that you really think a little bit about this disease overall, about the pathogen, about its unique virulence factors, about the fact that there are only certain antibiotics that work against this pathogen because of its basic nature, in particular its cell wall structure. It is an intracellular pathogen. We have a suite of antibiotics that mostly work right now, but we do have growing drug resistance. So this is a really good pathogen to understand better from the point of view of antibiotic resistance. But this is also a good pathogen for starting to learn a little bit about the immune system, right? So starting to learn about the innate immune system and those phagocytes, the macrophage and the dendritic cells, and then how those dendritic cells are converted to something called antigen-presenting cells, which then call in what is the adaptive immune system, which includes B cells and T cells. That's a really good starting point for learning a little bit about the immune system. So I will close with that.